afternoon, we'll be starting with a first roundtable with data at the heart of the health response in the face of health crises. The collection and analysis of geospatial data play a key role in guiding action. Tools such as health information systems, geographic information systems, GIS, contact tracing and crowdsourcing enable more detailed and immediate monitoring of epidemics. This roundtable will explore the contribution, limitation and prospects of implemented or experimental technologies such as drone mapping. Please welcome for this roundtable Dr. Raoul Kamadjeu.
Venez me rejoindre.
Please come on stage.
Justus, Nsio,
Mbeta. Please come on stage.
Le docteur Pilar Hernández.
Dr. Pilar Hernández.
Allez, venez vous asseoir.
Please come on stage.
Tous les trois, prenez place.
All three of you, please take a chair.
Et on va également, voilà, une fois que le générique
and sit down there.
Venez vous installer. Et on retrouve également connecté depuis Genève
online
en live avec
from
nous.
Geneva,
ça me permet de tous ceux qui sont connectés cet après-midi. Bienvenue à tous. On va retrouver voilà Asaad, Kadhum. Bonjour,
Asaad, Kadhum. Hello, can you hear us?
Hi, good afternoon. Affirmative, I can hear you.
Good, very good. We can hear you very well too. Thank you for being here with us. Thank you so much. Je voudrais qu'on ouvre cette, alors même principe que ce matin,
just like this morning, we've got half an hour, 35 minutes of discussion with you, and then we'll answer to the question. I'd like to start this roundtable with you, Raoul Kamadjeu. You are a specialist with global health and public health emergencies for UNICEF, of course, and you've tested the use of drones to provide aerial images in crisis situations, especially when fighting malaria and cholera. You're a specialist of the use of drones. Could you just tell us how this all works, please? Please take a mic.
Je prendrai le micro en anglais.
Yes,
Alors,
I'll be doing this in English.
Okay. Okay, thank you. Really, thank you. You know, the good thing that when you are kind of bilingual is that you are sometimes confused even in your brain, in your chain of thought. But really, I want to thank the participant organizers for the opportunity. I didn't expect that. And I received an email one day, someone told me, hey, do you want to represent UNICEF at this meeting? I said, oh, no, why not? You know, I work in surveillance, and I'm an epidemiologist by training. You know, I work with several agencies, but I started my career as an epidemiologist with the US CDC, you know, back in the days where I worked with the CDC for 10 years. And then I moved to UNICEF. And we do public health emergencies, of course, in all countries, mostly in Africa. And I'm in charge of high-threat pathogens and also infectious diseases outbreak. So how do we use drones? Unfortunately, drones are getting bad reputation these days because you have drone intrusions, you have drone bombing, you have all kinds of bad things associated with drones. And one of the fear that we have as a humanitarian agencies is that maybe by using drone, we may kind of jeopardize our reputations. So, and that's why it's extremely important as a public health emergency professional or dealing with drones to be extremely sure that you know exactly what you want to do with a drone. A drone is a tool. It's just a tool. Just like, you know, you have a hammer in your toolbox. It's just a tool. So, and then you want to use that for specific purposes. But the good thing with drones is that the purposes for which drones are necessary in surveillance are well known. And I remember back in the days when we were doing cartography, we were relying a lot on Google Earth. But unfortunately, in those countries where we operate, the coverage of Google Earth may not be, you know, so refined. And but with drones now, we are able to get geographic coverages at an extremely local level. And that means a lot. So when you have a drone, you can actually get some highly detailed, highly granular image coverages of your area of interventions. So when you use that for, let's say, malaria, that means a lot. You can actually pinpoint those places that are suitable for the vectors. So you can, depending on the type of hardware that you have mounted on your drone, if you have high-resolution camera, if you have thermal sensors, you can be able to say, okay, in those areas, these are probably habitats that are favorable for, let's say, the malaria vector. So you can already highly specifically target the areas where you want to intervene in terms of vector control. So this is just one way of using the drones, and there's some interesting article published in the literature in association with some universities who have done that very successfully.
Mais comme vous le disiez à l'instant, les drones ont une mauvaise
Yes,
réputation.
but as you just said, drones have a bad
Il
reputation.
n'y a pas de peur vis-à-vis de ces nouveaux
Aren't populations afraid of these drones?
That's
that
an
they
extremely
fear
important
surveillance?
question. In fact, as experts, we want to rush to the hardware and start implementing. But when you are dealing with drone, the most important work is upstream. You want to make sure that you have all the required authorization by the government. That's extremely important. That you have a really important conversation with the community where you're going to operate the drones. And this is, for me, as a UNICEF, that was the most important part of our work. How did we engage the community? How did we discuss with them? How do we kind of explain to them that we are just using drone and this usage is highly temporary. They're not going to be there permanently. We are working with the government. These are extremely important aspects that you have to take into consideration.
Mais comment faire la différence entre une menace?
But how can you make the difference between a threat and medical monitoring?
So I think the most important thing is you have to, first and foremost, not only identify the area in which you are going to use the drones, you want to make sure you have the appropriate authorizations. And in Malawi, for example, I will discuss that tomorrow during my presentation. We get authorization to have to operate on a specific corridor. So the aviation authority in Malawi will tell you, you can only operate your drone in this specific corridor. You know, let's say a radius 40 kilometers around, let's say, the airport. So that's extremely important. And you also tell the community, so we are going to fly over only at specific time. And you can even involve the community into looking at the images that you actually get from the drone. So they know exactly what you're looking for. Just taking thermal images, not actual images that you were just taking, let's say, you know, humidity images or the ground temperatures, or you were just taking some other big geographic structures like, you know, rivers and stuff like that. They are part of the conversation.
Dites-nous quels sont vos retours d'expérience, lessons learned.
What did you learn
So
from
lessons learned when you're dealing with drones, first and foremost, do you have the adequate, you know, technical expertise on the ground? So that's the first thing. You need to make sure that you have what is required to operate the drones. That's the first thing. And the second thing is that you want to make sure that the government is part of it. If the government is not part of it, you cannot even start to operate. That's the most important thing. As a humanitarian agency, you want to make sure that you clearly, you know, operate within the boundary of what is ethical and what is privacy concern, what all the confidentiality associated with it, because you don't want the humanitarian agency to appear as a kind of arm of the government participating in surveying or, you know, spying on population. So, in fact, the reflection is, how do we make sure that humanitarian actors using drone are not just put in the same basket as the military using drone for other things? So that's the most important. And finally, is the, you know, of course, how do you not only scale up, because scaling up is not usually what you want to do. So just making sure that it's streamlined as part of the normal humanitarian operations. So just that, okay, after this big, let's say, typhoon or cyclones or a big storm, the government would say, maybe we need a drone to survey the area and evaluate and assess the damage. So this is part of the thinking. And when the government start to think like this, the use of drone will become, you know, more mainstream.
And I'm sure you'll have a lot of questions coming up. Il y aura des questions pour vous tout à l'heure. Je voudrais qu'on entende
We'll have more questions for you. Let's listen to Dr. Pilar Hernández.
À la Fondation SORMAS. Depuis la Covid, de nombreux enseignements ont été tirés concernant la prévention, préparation, réponse
business development and project
et
for
l'expérience a montré
the
la valeur
SORMAS
des outils
Foundation.
numériques open source.
Open source digital tools, you've been working on this, and you've also discussed the question of their interoperability. Could you tell us more about this SORMAS project? This project is a tool for monitoring of and surveillance of infectious diseases. Could you tell us more how it works? And then later on, with Koshal, who can make it today, I'd like to listen to you, please, today.
I'm going to speak in English. So first of all, thank you for the invitation of being to be here. Unfortunately, I'm replacing Koshal Sobidi, who we will see in some minutes. Koshal is the SORMAS focal point, working at the Ministry of Health in Nepal, and he has not been granted his visa to come to France. So I'm just highlighting this fact because when we meet in conferences, we always talk about collaboration, cooperation, and we really need to get our governments to help us really implement these projects in a cooperative manner and collaborative. And granting a visa of a person working at the Ministry of Health in Nepal is the very first step to share the experience firsthand. So, Koshal, I know that you're watching. We're missing you here, and we really appreciate your work, which is oftentimes in the middle of the mountains. Sometimes when we speak, he's in the mountains, with very bad connection, responding to an disease outbreak, and trying to do his best, as all other health workers in Nepal, to protect the population from infectious diseases. So I just wanted to acknowledge that and say that, of course, I'm very happy to be here talking about SORMAS, and I hope we get to see Koshal and then to present. So about SORMAS. So SORMAS is open source software. It is a recognized global good, and I'm also highlighting that because being a global good and digital public good, it is kind of a recognition that is so you need to fulfill some criteria to be qualified as digital public good and global good. And it means that this software is already mature. So SORMAS started 10 years ago in the aftermath of the Ebola epidemic in West Africa. And it was a collaboration between the Nigeria CDC and a research institution in Germany. So from the very, very beginning, it was design, user-centered design done in collaboration between German researchers and users. When I mean users, I'm going to explain you in a second what do I mean by users. So users in Nigeria. So SORMAS, you should imagine, it's a platform, and then to this platform, there are different roles. There are different professionals at the different levels that are connected. So people at the community level, people at the laboratories, at the hospitals, at the points of entry, very important in when there are outbreaks or epidemics, so airports, ports, people at the Ministry of Health. So everyone has a role and access to the platform and can enter the information in the platform at their level. If they are working in the lab, they will enter the laboratory results. If they are working at the airport, they will enter the information of passengers coming in with whatever symptoms, and so on and so forth. So basically, everything is in real time. Everyone is sharing the information on the same platform and in real time, and everyone retrieves the information they need at their own level. And that's extremely important in terms of responding in a situation, in a crisis situation like an outbreak, right? Because we tend to think, oh, decision makers need the information, but everyone is a decision maker at all levels. So a person at the community needs to have information on what actions have to be undertaken at the community, messaging, promotion, if there is a whatever outbreak, dengue outbreak, whatever, laboratories, everyone needs to have this information. So basically, SORMAS allows you this entering information from all the different points in the health system. Also, we are integrating environmental health, so also from the environment. and then responding very quickly. But very importantly, and also that has been mentioned today in the beginning, so SORMAS allows the surveillance, the routine surveillance of the countries as well. So basically, we are talking about crisis, but to avoid a crisis, you really need to have a surveillance system that is ongoing and being maintained all the time. So importantly, you have a system that is able to pick up these signals before they become a crisis, before they become an outbreak. And if there is an outbreak, then being able to manage as soon as possible, as quickly as possible, and as effective as possible this outbreak. So in a nutshell.
Et on va entendre Kaushal parce qu'il n'a pas pu.
And now let's listen to Kaushal, who couldn't come because of visa issues, but he shared a little video with us. So he's a healthcare inspector for the healthcare entities in Nepal, in charge of infectious disease over there in Kathmandu. And we'll see with him what is the key element for the adoption of this tool called SORMAS. So he's got a little video for us. Let's have a look at it.
The key for the adaptation of tool in context of Nepal. So initially, we started from the 2 provinces in Nepal, and now we have completed to 4 provinces. And soon, in 2 or 3 months, these SORMAS will be implemented to all the provinces in Nepal, covering around 10,000 institutions using this SORMAS tool. And recently, we have introduced the community-based surveillance, and in this community-based surveillance also this SORMAS tool will be used. So all the features, the major features that this tool has, and what made us to use this tool is, first, it allows for the real-time surveillance, and it's open source. It can be customized by our own. It's interoperable. So we have been customizing this tool. For example, we have used this tool for the receiving of any signals or the events directly from the community using a hotline number call center. So the call center staffs use this tool to record all the calls and respond to those calls. And besides this, we have been using it to record all the information that are published in the media. So it's a media scanning. So we have integrated these epidemic intelligence from open sources, this to the SORMAS tool, where the health worker can see if any unusual news of outbreak probability or outbreak, if that has happened in any part of the country or the nearby country, that will help to verify the outbreak to the health workers. So these features are also being added by the Nepal in the SORMAS tool. So it's customizable, it is interoperable. So this is also another good point of this tool. So, and then it has a system of case-based surveillance, and it works offline. So it works both on the mobile and the web version.
It's a bit cut, but do you want to add something? Do you want to add anything that has not been said yet on?
No, well, I think he has explained that quite well. So, yeah, no, I don't want to.
Il y aura peut-être des questions tout à l'heure.
Well, we might have questions afterwards. So, let's move on to you, Justus Nsio Mbeta. You are Deputy Country Director of the Africa CDC Country Office in DRC. You are an epidemiologist with over 20 years experience in epidemic monitoring. You've dealt with many epidemics during Ebola. You were in charge of the task force. What is important is the Go data system. Could you tell us more about how using this system enabled to come up with a concrete answer on the field? Thank you very much, Sophie. We need to thank the organizers for this very successful event. We've been learning so much since this morning. It's quite unbelievable. Now, during my 21st years as fighting epidemics, amongst which Ebola. I worked a lot with the ministries in DRC, but also with other countries that supported us. In DRC, following its context and because of the lifestyle of the populations are facing different types of epidemics. 5 of them are ongoing, and there is an ongoing Mpox and Ebola epidemic. We've got cholera, we've got measles, polio, and add to this any catastrophe. It's not easy. I mean, if you don't have the tools to react at this level, it's really not easy. And this is why we need to thank those who are working backstage. In the world, we've had over 30 epidemics of Ebola. You mentioned 2018 and 2020 because they were quite special. What was special about them? Well, in the past, we managed very local epidemics. This epidemic came within the context of an armed conflict. There was no trust between the population and the managers or country's governance, and travel was very difficult. And so to manage Ebola. Now, if you want to understand how this tool helped us. Well, to manage Ebola, which is a zoonosis, which is scary because of its transmission mode. In order to manage Ebola correctly, we need to monitor all the people in touch with the first contact. So you need to monitor all the contacts, not miss one single one, because you can only pass the disease on once you're sick, and you can only be sick if you are in contact with the sick person. And so to make sure that we manage properly this epidemic, we need to make sure that any case of Ebola must be registered. And when there is one case which hasn't been in contact with anyone, you need to see where this comes from and question all your results. Now, for every case, we get some 50 to 100 contacts, and so it's not simple. When it's 10 or 20 cases or contacts, it's easy. You can try and control manually the chain of contact when you have thousands of cases, because we've had over 3,000 cases. It was very difficult in various places, in several places, several locations. We thus needed a tool which would enable us to see where these contacts were in real time and understand if you control the epidemic or not. So this is where GoData comes into play. GoData enabled us make decisions because thanks to contact management, we could look for new cases that were unrelated. Take, for instance, the Mabalako case, because this was next to the Kivu Lake. And we also found a case that came out of nowhere, and in fact we realized that this was a chain that led us all the way to North Kivu, and in fact came even from South Kivu. And this is something we managed to spot thanks to GoData. Okay, could we maybe broaden the scope and take a distance from your experience? What any other solution was put forward for managing epidemics? Well, GoData can help, but when you manage epidemics, take 2012, we had another epidemic. It was typhoid fever, and this really was quite a predicament for us, because we needed to understand where this came from, how it happened. We thought that this epidemic was a zoonosis, not a zoonosis, but came from a hospital, was a nosocomial infection. and we thought it came from water. We spent a lot of money, but we didn't manage to stop the epidemic, and so we used a tool of geolocation called QGIS in order to make clusters in order to investigate. And we realized that the lion's share of cases came from one place just close to the road. And as we investigated further, we realized that it was one market that where everything was done underground, and they had no sanitation, and there were just open defecation everywhere. And so all this money we spent on chlorine and in hospitals, in fact, we realized it was pointless. All we needed to do was to put toilets and solve and get a little bit of hygiene into this market, and it was nearly the end of the epidemic. At least it went down very quickly. And so we also use a certain number of trackers now, which enables us to understand the chain of the epidemics from an alert all the way to case management. Individual cases are managed like this. And now we are working on this tool, and the current Ebola epidemic is now managed and handled thanks to this tool. Thank you very much. We'll be back with you for the question. Let's take a plane to Geneva in order to speak to Asaad Kadhum, Regional Public Health Officer at the UNHCR. You do not have a headset for translation. I'll put this question in.
Given the theme of today's event that we are interested in right now, you say that you're taking a step back from digital health. Why is that?
Thank you, Sophie. Good afternoon, colleagues. And like I would just start to say good afternoon to the panel member, colleagues, and the participants, and thank the organizers for the invitation, and also like join this important discussion on how to drive or how to use the data-driven health responses in a humanitarian context and to inform decision-making. Before like answering the question, we didn't really take a step back when it comes into UNHCR use of digital health system. It's more like we transform or change the way we deal with health data. Maybe just before really answer the question, to give a little bit or to tackle a few issues or shed light on some aspect that will make it easier for the participants to understand the decisions that we are doing. Like elements important for the discussion, including the health data system in humanitarian settings, more specifically in refugee or displacement settings. The first is the type of health data system in a humanitarian setting. So when we speak about displacements, particularly refugee operation, our approach to data, it happened through two key lenses. One is the health information system, this the DHIS, and there is a specific version of it. In UNHCR, we call it the IRHIS. It's Integrated Refugee Health Information System. It's basically a system where we collect aggregate data, and this is essential for planning, monitoring, and evaluating health responses. So this is one aspect. The second is electronic health record. Basically, this captures more individual patient data and are critical for continuity of care in a program like non-communicable diseases or EPI, ANCPNC, or TB and HIV. For us, when it comes into the refugee crisis, as you know, we are now hitting 123 million refugees worldwide. The displacement is getting really high, and the burden of disease is also changing. So we are having much more disease burden for non-communicable diseases compared to 20 years ago, where the main, let's say, disease burden were communicable diseases. So that's why we see this as an important reflection on how the health system that we are working on will basically benefit the planning, but also the disease burden that we are working on. So the second is the infrastructural challenges. So when it comes into digitalization in a humanitarian health system, we face significant infrastructure barriers. Like, for instance, 70% of the 123 million that I mentioned are basically hosted in low and middle income countries, many of which lack the digital infrastructure to support a robust health data systems. So in conflict zone like Sudan, as you saw last year, we have experienced a prolonged internet outages, severely impacted the data reporting and coordination. We were basically on the blind side of the things for quite a few weeks. And we tried to basically like lean on other ways and old methodology to collect data. Also, when it comes into refugee camps and settlements, it's often located in remote and border areas with limited connectivity. So this is also something that we take into account when we roll out the system itself. But there is obviously an optimist when it comes into emerging technology, like the satellite internet, Starlink, which is becoming more accessible and could even transform the connectivity in these settings. Now, the third element is the coordination and the fragmentation. One of the persistent challenges we have is the fragmented data collection across multiple partners. So when we have like refugee emergencies, especially at the beginning of the emergencies, we have multiple responders, including local NGOs, international agencies, government entities, primarily obviously Ministry of Health, which use different systems. It makes it much more complicated, like to use one data system that respond. Because I mean, we obviously also understand that some of the partners, they have their own, like let's say, different use of the health data. Some are used for donor perspective, others are for reporting. But our interest is mainly to use the data to inform planning and to see. For us, from this point, we looked into the development of the IRHIS, which is the Integrated Refugee Health Information System. It was developed like 7 or 8 years ago. There has been different version before that. And it's basically a comprehensive health information system tailored for refugee setting. It includes modules like outpatient and inpatient care, laboratory and nutrition services, like sexual and reproductive health, but also have a disease surveillance and alerts. It collects very good indicators. It can be used by most of the partners. So in multiple settings, some of the partners, obviously, they don't provide the same level of services. So that's why we have the aspects of it can basically be tweaked according to the needs of them. So if a partner is doing only mobile clinics or the other is doing only, let's say, SRH, you could choose this module. And it was quite useful also in generating alerts, like in refugee camps or even settlements, it tend to be overcrowded settings, and it's also subject or it have high risk of communicable diseases. That's why we are very keen to keep a very good eye on the disease surveillance, most of the times in coordination with ministries of health, but also to use the approaches, including this, to generate alerts. So for instance, if we have the system is having the capacity to generate alerts if there is an aggregate number of mortalities from a specific area. If we have like 3 weeks in a row, bloody diarrhea, it will generate alerts. So it helps us really keep a good eye in terms of, like, let's say, epidemic surveillance, and also to make sure that it responds to the partner and our need. The last point is the strategic shift, and this is which basically will answer your question. So UNHCR as an agency, we are shifting toward integration with national health system. We are trying to avoid having a parallel humanitarian system when it comes into delivering health services for the refugees. We try to align our health programs provided and by the national health system, and this would include the data collection stages. So this is where it comes our plan to start to shift toward DHIS. DHIS is basically adopted quite widely. It's the District Health Information System, and there is version 2 of it. And we aim to shift from the IRHIS that is more UNHCR tool to DHIS that is much more integrated at national level as a platform. And we plan to phase out starting from next year, from 2026. We are starting from the beginning of the year with a plan for a full transition into the national DHIS platform toward the second half of the year. We would be looking into areas like interoperability, data harmonization, and strengthening national ownership also. So those are the main aspects that we are looking into. And also the DHIS, the good part of it, and I forgot to mention this point, it's have some components of electronic health record. Like if you take the DHIS, it have a component of LCD, and electronic health records tend to be a little bit more intensive in terms of technical requirement. But we also acknowledge that it's quite important for instance, like when it comes into us in the context of return. We have refugees returning to their home countries. They need to have access to their health information, although there is a challenge with the data protection and other elements, but it's something that we still need to look into. And this is why another reason, let us look into having the DHIS as adopted, and we will do that over a period of 3 years. it's more help like having the data harmonized and give a platform that is accessible by us and all of the other partners that work with refugee health and work with providing health services for the refugee. So let me stop here and happy to have any questions.
Yes, probably. Thank you, Asaad. We'll open the floor to the questions now. On va ouvrir effectivement les questions. Il y en a quelques-unes déjà.
We have a few questions from the floor and we'll take some in the chat. I can see hands raised. Could we bring mics to the hands? Please keep it short and sweet so that we may have as many questions as possible.
Synthétique, comme... Bonjour, monsieur.
Bonjour. Question très rapide.
Hello.
Salut Diop,
Yes,
Sénégal.
I'm from Senegal, and I have a question. I think the speaker started mentioning how to change this situation where every entity has its own database, and how can we have an integrated, sustainable, harmonized database. And if I understand correctly, this DHIS is this type of approach. I know that this DHIS is being rolled out in several countries, and we are moving on to pilot phases, but I think that this DHIS is finding it difficult to be adopted. What are the constraints? What are the issues in implementation in DHIS in the different countries?
It is planned since now many years. An example in Senegal, I think that DHIS is there as a pilot study, as pilot, but not really fully implemented. What is the constraint and what is the weakness on making this platform implemented really?
Asaad, did you hear the question? Do you want to provide some sort of answer first, and then we'll go around the table? But we cannot hear you anymore.
Sorry, do you hear me now?
Yes, perfect.
Wonderful. So if I heard the question, well, is about the challenges with moving toward the DHIS tool.
Right.
So obviously, yes, there are challenges. And if we see the countries, as the colleague mentioned, that there are different level of progress made in the different countries when it comes into the implementation of the DHIS. So we don't have like one size fit all approach when it comes into rolling it out, because also when it comes into our interest, it's basically not, it would focus on the countries that have high burden of or high number of refugees operations, like countries like Ethiopia, Kenya, Uganda, and so on. So we do a tailored one. We have like a sort of a partnership we created multiple partnerships, including one with an ICT company called Carto-NG, but also we have the like an additional partnership to see how we can facilitate. So one international, but we also have developed local partnership with the Ministry of Health to tackle aspects including hardware issues. Sometimes it's related to hardware, sometimes it's related to servers, sometimes it's related to different aspects. So with these partnerships, we create a plan. So we do an initial phase, and this is why I said it will happen over 3 years, because we realize that this is not something that can happen overnight, and it would require quite a lot of efforts to make sure that it is sustainable, work well, and basically respond to the needs of the different partners that going to utilize it. Otherwise, like you said, we saw lots of fragmentation, because many of the partners, when it comes into the provision of the health services, they would focus on their own needs. And as soon as they see a system that is not really responding to their needs, they will start to adapt their own. But that doesn't help at all, because there is no continuity of care. There is no, like, let's say the whole point of utilizing the health information system is to have it like coordinated, like, you know, multiple partners using it, and then it will give a very clear idea for everyone. So partnership is key. Understanding what are the needs in the different context is also key, and also making the necessary investments from the beginning. This is the way we are approaching it, with the say no one size fit all. Over.
Raoul, partnership is key. Pilar et Justus, est-ce que vous voulez aussi compléter? Quel est votre point de vue?
Do you want to add, Pilar? Just this partnership is key.
On DHIS2, that's
yes.
the current version that is being deployed. And I know you have different level of adoptions by countries, and even within the same countries, you have different districts at a different level of implementation. And I think the challenges are always the same when it comes to the adoption of DHI. So where we have some governance issues, some just human resources issues, some practical issues on the ground in terms of connectivities, in terms of electricities, in terms of even availability of human resources on the ground. I've seen during my visits in various countries to respond to outbreak that there are different levels on a lot of things. Maybe just to add something, just a reflection around digital health in general from one of my great mentors when I was still in the informatics field. It was that digital health should not be a solution looking for a problem. It should not be a solution looking for a problem. It should be a problem. It should be a solution to existing problem. And one thing that he always said was that if you have a system that doesn't work, you can digitize it all the way you want, it will still never work. And one of the mistakes that we make, it has nothing to do with GHIS, let me point it out, which is a very successful initiative in my view, but in digital health in general. He was always saying that if a system doesn't work, you can digitize it as much as you want, it still won't work. But if you have a system that already works, and you come in with digitalization, you will make it much better. That's always what he was saying. And one last thing that he was saying is that smallpox was eradicated with pencil and papers. We have the technology, including EI, but we are still struggling to eradicate the polio, and we have problem with all the old diseases that are coming back. Just a food for thought when it comes to digitization.
Exactly. Thank you. Merci. Pilar, do you want to add something?
I can only confirm what you just said. So I think in terms of adoption, we should consider two aspects. The one that is regarding the tool. So of course, is the tool adapted to the context? Is it, as we have discussed before, is it, if there is no internet, is the tool able to work without internet, etc.? Does it have a mobile version, etc., etc.? Then also on the tool, is it really useful? Because some of the projects or some of the digital tools that are being developed, and maybe in line with what you just mentioned, so are they really solving a real problem of a person? So are they really addressing what the users need? So I keep on using that word user, so you understand that user is all the people in the health system that need digital tools to do their work. So because and that's why I would like to highlight the fact of whenever we are doing something, designing something, it really has to be user-centered, because if we are not starting from the very beginning, involving the future users, then the risk is very high that when we have something done, then it's not gonna be useful for the people who is intended to be useful, to be designed for. And then something that is important as well is these tools have also to be developed, because we always talk about developing something for someone, but this is developed by someone that can be also the user. So in the case of Kaushal just mentioned, so the team in Nepal has developed something, an integration of news screening into SORMAS, and this is being integrated in the main branch and made available for the whole community in the world using SORMAS. So it is not only one side; it is like bi-directional, multi-directional. So that's on the tool, and of course, that's the other second aspect that has been also mentioned before, which are the things like logistics. So if we have a tool that is already designed, it's proved its usefulness, then it's scaled up, but we don't have the resources that are needed to the regular use, like data bundles, for example, salaries of the people, like working there, or even if it's open source, who's maintaining that? People are not working for free. So basically what I'm trying to say is we really need to think of the invisible part. We really need to make visible the invisible, because that part is what is really important, and it's not only the HIS2 or SORMAS or Go data or whatever. It's common in all digital tools. The important part is usually the invisible, and it's all the things that I'm saying. So yeah, I think it's important.
Thank you very much, Pilar. Justus, est-ce que vous avez quelque chose à rajouter sur cette question?
Bon, ils ont
Justus,
presque
you want
tout
to add
abordé,
anything?
mais s'il faut ajouter un petit rien,
Yes, they have spoken about everything. I think it has to do with governance and with everything that was put forward in terms of investment. So we have solutions that can be very different from one country to another. Having said that, you have countries where you have found tools that were very efficient, and they are still efficient today, and they were stopped just to go to stop and switch to another one. I think we need to have a decision and a plan to know how we go forward. If there's interoperability, how do we go forward in a step-by-step way? If there's interoperability, of course, there's the issue of we have seen some countries that started, and then we need to have a tool that works well. I think it's a good thing, but to have two, it's really good, because there's interoperability, and we have all the data, whether they're one tool on another one plus a backup, you mean? Yes. There's a question here, but there's another one before. Just before, and then we'll have the...
Thank you for your insights. I was going to ask another question, but I'm going to pick up on this concept of user centricity, which is obviously so important. I've worked in industry for many years, and that's often, a mantra that is used. The challenge that often people who are in the building space face is the thing or the value for the individual user or the clinical end user goes against what is seen as valuable or perceived as valuable by the system decision maker. And often, particularly in our macroeconomic context, is the big criteria that is winning right now is, does this save money, or if you're another type of health system or other thing, like, does this get us revenue? And often that goes against the thing that is the user need. How do you balance that? How have you thought about that? How have you wrestled against this?
Who wants to give a bit of answer?
Yeah, maybe very quickly, because I also used to be a developer, a programmer. We develop a lot of systems. But the advantage that we have is that we are not part of what I would call the industry. So the bottom line, the money is not our motivation. But unfortunately, there's another bias. I would call it the programmer bias. As a programmer, you want to develop cool stuff. You're always excited when you come up with the coolest stuff possible. And the usability engineering of what you're developing is usually not your primary concern. So, and when that rubber hits the road, that's when we realize that, oh my goodness, we were so off track. So just to say that in the industry, they have the bottom line that is guiding everything. In the humanitarian sector, they have other biases. They want to be the first to push the coolest thing out there. The programmers, they are convinced that if it's so beautifully designed, if the code is so neat, it's probably going to work. But unfortunately, this is another, I don't know if that figure has changed. We used to say, when I was in development, that 95% of IT projects in the field of health will fail. 95% will fail. And that's very true, unfortunately. The one that we see are the result of an extremely severe Darwinian, principle going on there. But I totally agree with you. But we should be looking at the project that fail. And that's usually what we don't do, unfortunately.
Asaad, raise your hand if you want to add something, of course. Huh? You're here with us. MS, on prend votre question.
Merci beaucoup pour la parole et merci aux panélistes.
Thank you very much to give me the floor.
It's
extremely interesting.
Et généralement, lorsqu'on a la gestion des
when
données,
you are managing data,
en réponse sanitaire en contexte de crise, on a
when
souvent
you
les
are in
questions
a
de
crisis
paternité, de souveraineté.
context,
le DHS2,
you
par
have
exemple,
the
c'est un outil vraiment
question of
formidable qui a
paternity
mis en
and
place
sovereignty.
de pays actuellement, mais dont les données ne sont pas souvent
Often
lorsqu'elles sont
data
logées au sein de ces
not
pays-là. Quelle est la solution qu'on peut apporter
aggregated.
à
What
cela?
solution can we
Et
bring
l'autre
to
point
that. And then the other point is about paternity of data. Often we did it with COVID. There are many international organizations and big companies that are carrying out work in inquests. And then final results, they own the data and they don't share it. At a local level, we don't have access to the data collected. How do you manage this in a crisis situation?
Ok, merci beaucoup. Je pense que
well, thank you very much. I think the question you are raising is really a very important question. And we're facing this when we are facing a tool at a ministry level. The key question is where are located data, where are they hosted, their personal data, where are they being hosted, where do you find them? It depends really of the exchange you have, the relationship you have with the producer of the tool, the one that is hosting the data. If the country has this autonomy, it can demand to host data at home, so to speak. So it works it happens in emergency situations. You don't even have time to think about it. You need to face emergency situations. And therefore, you start taking data where they're being hosted, and then you see how you can negotiate, how you can use it. Even if the data are far away, you need to know who owns the data, how do you have access, and how do you use it. And I was talking about that with many countries, and it's really the question. And even if Congo country, the orientations of the country really push us to really host the data at the level of the country. Now we're going to take two questions in the chat. I'm going to take one for Pilar. What are the main issues met when you implement SORMAS in different countries?
Well, yeah, so let me pick some. So maybe one of the things that we face frequently, so let me put it this way, frequently, is that we see that there is like funding, for example, but there is funding for a pilot. So SORMAS is already a mature software, it's a scale-up. For example, it's a national surveillance system in Nigeria, in Ghana as well, Nepal as well. But for example, there are other countries that started with pilots, with a little bit of funding, and then they don't, because the funders, and maybe that's something that we need to start thinking in another way. So there should be a shift of thinking, of short-time thinking to long-time thinking. So one of the problems that we face often is that there is funding for a small pilot, and I'm talking about even pilots going for 6 months. Yeah, even. And then after that, of course, that's not enough time, like for a country to adopt the system. So in 6 months or in very few months, with a little bit of funding, that's not enough for train enough people, to get train and even retrain, do scale up, do the national rollout, and so on and so forth. So very often we see very short-sighted interventions. So that's one of the challenges that we face the most. That's the one thing. And then second, it's like a lot of lack of alignment of different stakeholders. As I think it has been mentioned as well, it's seen all the time. So there should be sovereignty of the country to decide which tool to use. Of course, we will recommend to be as a mature software. DHIS2 is a mature software, is also a global good as well, Go data as well. So, but at least there should be some alignment. When a country decides to use a tool, then it should I think there should be an alignment and respectful of the decision of the country. That's not often what happens. So, because many organizations and donors are rather driven by the data and not so much by the strengthening of the surveillance system, and that's extremely important to understand. So the systems are not there just to extract the data. The systems are there to use the data to make public health decisions. And that's not clear to everyone. So we should really stop thinking short-sighted, and we should stop thinking on data. So rather more like, what are we doing this data to stop diseases from happening and, of course, saving lives.
Thank you. Merci beaucoup, Pilar. La question suivante, elle est pour vous, Justus. Comment conjuguer l'utilisation des données pour le suivi en temps réel avec les problématiques d'accès à la connectivité dans
with
les
the
zones
issues
rurales?
of access of connectivity in rural areas?
Oui, c'est vrai, ça c'est un problème
Yes,
sérieux au niveau
it is
rural
rural areas, it is a real issue. You have areas where there are hotspots, but there is no connectivity. So we manage this with tools that can work offline.
Et donc, avec ces outils-là, on peut
Thanks
faire
to
la
those
saisie
tools,
des
we
données
can
localement, même la
actually
géolocalisation.
use
Mais lorsqu'on arrive à un
geolocalization,
point où on peut avoir la connectivité,
but
alors
when
on
you
peut
have
uploader
connectivity,
toutes les données.
then you can
Ça, c'est
have
de un.
all
Et
data.
de deux, aujourd'hui, avec les solutions
with
comme les
geospotting.
Starlink,
Then with
ça nous
Starlink
permet
as
maintenant
solution, we can now have
des antennes isolées dans des
antennas
endroits où
that
la
are
connectivité
isolated,
n'est pas là,
where
où
connectivity
l'équipe est autour
is
et on
not there,
travaille
but
et
there's
en
a
temps
team
réel pour avoir les
around
données
the
pour les
antenna. We
analyses.
can have
Je pense
real-time
que
data
ce sont là
to analyze them.
les
And
solutions que
I
nous
think
sommes
they
en
are
train
the
d'utiliser pour le
solutions
moment.
that we're using at the moment.
Merci beaucoup pour vos questions dans la
Thank
salle
you
et
very
merci
much
à
for
vous
your
aussi de
questions.
nous avoir
Thank
adressé des
you
questions
very much
via le
to
chat.
have
Merci
given us
infiniment,
questions via
Madame, Messieurs,
chat
pour vos propos
box.
très
Thank you
intéressants.
very much
Thank
for
you so
your
much, Asaad, for being
dialogue
with
and
us
for
this
being
afternoon
here.
from Geneva. You take care. Thank you very much. Merci beaucoup.
Thank you very much.